Foundations of Office Gynecology and Early Pregnancy Care. Episode 12, Early Pregnancy Loss Management and Counseling. After the diagnosis is secure, management should become calmer, not more automatic. Lecture 11 was about diagnostic safety, certainty before evacuation, and location before treatment. This lecture begins after that step. The pregnancy loss has been confirmed. Ectopic pregnancy has been handled or reasonably excluded for the management decision in front of you. The patient is now asking, what happens next? The dominant model is this: 3 safe doors. Time, medication, procedure. Expectant management spends time. Medical management uses medication to speed uterine expulsion. Surgical management completes the process directly. None of these doors is morally superior. None is the real treatment, while the others are compromises. The best door depends on urgency, contraindications, patient preference, access, support, and follow-up. That is the first resident reflex. Once diagnosis is secure and the patient is stable, preference matters. But stable is doing important work in that sentence. Before offering all 3 choices as equivalent, ask whether the patient has hemorrhage, hemodynamic instability, infection, severe anemia, a bleeding disorder, cardiovascular disease, or another medical reason that makes waiting unsafe. If yes, the decision narrows. Safety comes before preference.
If no urgent complication exists, ACOG supports expectant management, medical treatment, and surgical evacuation as accepted options. They differ in process, but there is no evidence that any approach leads to different long-term outcomes. The patient should hear the risks and benefits of each option in a way that lets her choose without feeling pushed. Start with the first door, expectant management. Expectant management is generally limited to the first trimester because later gestations raise more safety concern, especially hemorrhage concern. With adequate time, up to 8 weeks, expectant management achieves complete expulsion in about 80% of women. It may work better when the patient is already symptomatic, has past tissue, or has ultrasound findings consistent with incomplete expulsion. It may be less predictable in missed or anembryonic loss. The mechanism is simple. The body is already in or may enter the process of expelling the pregnancy tissue. The benefit is avoiding medication and procedure. The burden is time, uncertainty, bleeding, cramping, and the possibility that surgery may still be needed. So never describe expectant management as doing nothing. It is active waiting with instructions and follow-up.
The patient needs to know that bleeding can be moderate to heavy, and cramping can be significant. She needs pain medication, written or clear verbal instructions, and a specific plan for when and whom to call. She also needs to know that needing surgery later does not mean she failed. It means the first door did not complete the process safely enough. Follow-up after expectant management should confirm complete passage. Often this is done by ultrasound, showing absence of the gestational sac. A commonly used criterion has been absence of the gestational sac with endometrial thickness less than 30 millimeters. But the endometrial stripe is a common trap. ACOG notes that there is no evidence of increased morbidity in asymptomatic women with a thicker endometrial measurement after treatment. Surgical intervention is not required in an asymptomatic patient simply because the endometrial stripe is thick once the gestational sac is gone. The resident reflex is this: treat the patient, not the endometrial stripe. Ultrasound follow-up should not become a search for a perfect-looking uterus. Its main diagnostic purpose is to document absence of the gestational sac. Symptoms matter. Bleeding pattern matters. Fever and pain matter. Now, the second door, medical management. Medical management is appropriate for patients without infection, hemorrhage, severe anemia, or bleeding disorders who want to shorten the time to complete expulsion but prefer to avoid surgical evacuation.
Compared with expectant management, medical management decreases time to expulsion and increases the rate of complete expulsion without needing surgery. The preferred regimen when mifepristone is available is mifepristone 200 milligrams orally, followed 24 hours later by misoprostol, 800 micrograms vaginally. Misoprostol can be repeated if needed. The repeat dose should be no earlier than 3 hours after the first dose and typically within 7 days if there is no response. Misoprostol alone is also effective. In the largest United States randomized trial cited by ACOG, 800 micrograms of vaginal misoprostol led to complete expulsion by day 3 in 71% after one dose and 84% after a second dose. The mechanism helps the regimen make sense. Mifepristone blocks progesterone support and primes the uterus. Misoprostol is a prostaglandin analog that causes uterine contractions and cervical change. Together, they make expulsion more effective than misoprostol alone when mifepristone is available. A 2018 randomized trial showed the combined regimen increased complete expulsion compared with misoprostol alone and decreased the need for uterine aspiration to complete treatment. Serious adverse events were rare. Now, counseling. Medical management is not just handing over pills. It is a planned process.
The patient should expect bleeding heavier than menses and potentially severe cramping. She should have pain medication. She should know that visible tissue passage may occur. She should know what is too much bleeding. A practical warning threshold is soaking 2 maxi pads per hour for 2 consecutive hours. If that happens, she should call or seek care according to the plan you give her. Follow-up typically includes ultrasound within 7 to 14 days to confirm complete passage. Serial HCG can be used where ultrasound is unavailable. Patient-reported symptoms also matter. If medical management does not work, the patient may choose more time with expectant management, if appropriate, or suction curettage. Again, needing surgery later is not failure. It is part of safe, stepped care. Now, the third door, surgical management. Surgical uterine evacuation is urgent for hemorrhage, hemodynamic instability, or signs of infection. It may also be preferable with severe anemia, bleeding disorders, cardiovascular disease, or other comorbidities that make heavy bleeding or prolonged uncertainty less safe. Surgery can also be chosen by patient preference. Some patients want immediate completion. Some want to avoid seeing tissue. Some cannot manage days or weeks of uncertainty. Some cannot return easily for multiple visits. Those are legitimate reasons. The resident should distinguish 2 different indications: surgery because safety requires it, and surgery because the patient chooses predictable completion. Both are valid, but they are not the same conversation.
Suction curettage is superior to sharp curettage alone. Routine sharp curettage after suction does not add benefit when the clinician is confident the uterus is empty. Suction evacuation can often be performed in an office setting with electric vacuum or manual vacuum aspiration, local anesthesia, and sometimes sedation. Office management can reduce cost and time and may be more convenient for patients. Surgical evacuation is also the most predictable primary approach. ACOG reports that success of surgical uterine evacuation approaches 99%. Antibiotic prophylaxis should be part of the surgical plan. A single preoperative dose of doxycycline is recommended to prevent infection after surgical management. Some experts recommend 200 milligrams 1 hour before the procedure. Now compare complications. Serious complications are rare across expectant, medical, and surgical management. Hemorrhage and infection can occur with all approaches. Hemorrhage-related hospitalization, with or without transfusion, is similar between treatment approaches, about 0.5 to 1%. Infection rates are low, about 1 to 2%. This comparison is important because it lets the resident counsel without fear-based steering. The patient should not be told that one approach is safe and the others are dangerous. She should be told what each option asks of her and what each option prevents. Expectant management asks for time and tolerance of uncertainty. Medical management asks for a medication process, heavier bleeding and cramping, and follow-up. Surgical management asks for a procedure, but gives speed and predictability, and is required when instability, infection, hemorrhage, or serious comorbidity makes delay unsafe. Now, RHD immune globulin. Although the risk of alloimmunization is low, the consequences can be significant. RHD immune globulin should be considered in early pregnancy loss, especially later in the first trimester. If it is given, the dose should be at least 50 micrograms. For Rh-negative, unsensitized patients undergoing medical management, prophylaxis should be given within 72 hours of the first misoprostol administration, if prophylaxis is being used. For Rh-negative patients undergoing surgical management, ACOG says they should receive RHD immune globulin prophylaxis because the risk is higher. Now, after the loss, patients often ask when they can try again. There are no quality data showing that delaying conception after early pregnancy loss prevents another loss or improves pregnancy outcomes. Small observational studies show no benefit to delayed conception. Abstaining from vaginal intercourse for 1 to 2 weeks after complete passage is commonly recommended to reduce infection risk, but ACOG notes this is not evidence-based. Patients who want contraception can start hormonal contraception immediately after completion of early pregnancy loss.
An IUD can be placed immediately after surgical treatment, as long as septic abortion is not suspected. Immediate IUD insertion after suction curettage has a slightly higher expulsion rate than delayed insertion, but the difference is not usually clinically decisive, 5% versus 2.7% at 6 months in the cited trial. This is another place where residents can improve care by not creating unnecessary delays. If the patient wants contraception, help her start safely. Now, workup after one loss. After one early pregnancy loss, routine evaluation is generally not recommended. No routine maternal or fetal chromosomal analysis, no routine inherited thrombophilia testing. This is not dismissive. It reflects probability and evidence. Early pregnancy loss is common, and about half are due to fetal chromosomal abnormalities. A broad workup after one loss often creates confusing results without improving care. No workup is generally recommended until after the second consecutive clinical early pregnancy loss. Thrombophilia deserves a specific warning. Although thrombophilias are often blamed for miscarriage, only antiphospholipid syndrome has consistently been shown to be significantly associated with early pregnancy loss. Anticoagulants, aspirin, or both have not reduced early pregnancy loss risk in women with inherited thrombophilia, except in the context of antiphospholipid syndrome. The resident reflex is this: one loss usually needs counseling, not a thrombophilia panel. Now, prevention myths.
There are no proven interventions to prevent most early pregnancy loss. Bed rest should not be recommended. Pelvic rest, vitamins, uterine relaxants, and HCG administration have not been proved to prevent loss. Progesterone is nuanced. Prophylactic progesterone has not shown broad benefit for preventing early pregnancy loss. For threatened early pregnancy loss, progestins remain controversial, and conclusive evidence is lacking. Women with at least 3 prior pregnancy losses, however, may benefit from first trimester progesterone therapy. This is how to say it clearly. Progesterone is not a universal miscarriage prevention treatment, but recurrent loss history can change the discussion. Now, counseling language. The patient needs to hear that this is common, that most early losses are not caused by something she did, and that choosing one management option over another is not a character test. For expectant management, say, this lets your body complete the process, but it may take time, bleeding can be heavy, and you may still need medication or a procedure. For medical management, say, this uses medication to make the uterus expel the tissue sooner. You avoid a procedure now, but you need to be prepared for heavy bleeding, cramping, follow-up, and the possibility of surgery if it does not complete. For surgical management, say, this is the fastest and most predictable option. It is urgent if there is heavy bleeding, infection, instability, or certain medical risks. It can also be a reasonable choice if immediate completion is what you prefer.
That framing gives the patient agency without hiding the clinical facts.
Now, the final synthesis. Early pregnancy loss management has 3 safe doors. Time. Expectant management. Generally first trimester, up to 8 weeks, about 80% success. Medication. Mifepristone 200 milligrams orally, followed 24 hours later by misoprostol 800 micrograms vaginally when available, or misoprostol alone with repeat dosing if needed. Procedure. Suction evacuation. Urgent for hemorrhage, instability, infection, or major medical risk, and also valid by preference for immediate completion. Counsel bleeding, cramping, pain control, return precautions, and follow-up. Consider RhD immune globulin, especially later in the first trimester, and give it for Rh-negative patients undergoing surgical management. Do not chase an asymptomatic thick endometrial stripe. Do not delay contraception unnecessarily. Do not order a thrombophilia panel after 1 loss. Do not recommend bed rest. The final resident reflex is this. After diagnosis is secure, match the door to the patient's safety needs and values, and make sure follow-up is real.